And NCLEX is very Med-Surg heavy. So that's where they're going to teach them. They're not going to teach them critical care or emergency room or operating room. So these students think that they have to go work in Med-Surg for 2 years before they could go do something else that maybe they really feel called to go work in the operating room.
Clock in, scrub up, and join us behind the red line. You're listening to First Case, a perioperative podcast bringing you exciting interviews, engaging discussions, and innovative solutions that are changing the way patients receive surgical care. Each episode, we talk to frontline staff, perioperative leadership, and nursing entrepreneurs from across the country as they share their stories, experience, and expertise on the industry we love. From the back table to the boardroom, from wheels in to wheels out, we tackle the real-life issues affecting the OR. Whether you're tuning in for surgical service education or inspiration, we're glad you're here. And now, it's time to roll back and start the first case.
This week on First Case, we're speaking with Lindsey Joyce, a cardiovascular operating room nurse at St. Luke's Hospital in Chesterfield, Missouri, and the coordinator for the Perioperative Nursing Elective at the Trudy, Busch, Valentine School of Nursing at St. Louis University. And Paul, I just can't wait to get into this discussion with Lindsey because it's all about getting experience as a new grad or an almost new grad in nursing school, specifically around the operating room, which I think is going to be so critical because I just remember being intimidated by the OR when I was still going to be a brand new nurse. And I worked as a CNA. I had a lot of healthcare experience and continued to work as I went through nursing school. And I found myself being more confident than most in my graduating class. And yet I still was intimidated by surgical services. And so I think programs like this are going to be really critical. And I'm interested to learn more about how Lindsey and the Trudy Busch Valentine School of Nursing set this program up and really what was the impetus for this?
I think it's really important for the OR to be a focus in the future for a number of reasons. You know, there's the total shortage of nursing throughout the industry, but the fact that nurses generally are not trained in the operating room in their programs makes it more difficult for them to go into that specialty. So if it can be an elective in a nursing program, or if it can be an additional program right after graduation, it makes all the sense in the world to me to promote this and get programs developed across the country.
Yeah, and I think it's ultimately going to help hospitals as well, even financially. So this is going to be excellent. And I'll even add, before we get into this interview, that as we were talking to Lindsey, she was mentioning the fact that, you know, really all of the School of Nursing programs are designed around much more Med-Surg because they're focused on making sure that new grads pass the NCLEX. And I think that may be why electives like this have not traditionally been included in these programs at various schools of nursing across the country. So again, really excited to get into this interview with Lindsey Joyce. And we're going to be right back after a short break.
Hi, I'm Paul Wafer.
I'm Melanie Perry.
I'm Jeremy Gibson-Rohr.
And I'm Justin Poulin.
A 17 Studios production, you're listening to First Case.
Joining us now is Lindsey Joyce, RN, MSN, CNL, CNOR, a cardiovascular operating room nurse at St. Luke's Hospital in Chesterfield, Missouri, and the coordinator for the Perioperative Nursing Elective at the Trudy Busch Valentine School of Nursing at St. Louis University. And so, Lindsey, I know you've been listening to the show and you reached out to see if we might want to have this conversation today around perioperative nursing electives and new grads in the operating room. And boy, are we glad you did. Thanks so much for coming on the show.
Yes, thank you so much. I'm excited to talk to you guys about this.
Well, we are too. And, you know, there is a looming nursing shortage. And so I have a feeling that this conversation is going to become more and more present, not only for people entering the operating room as new nurses, but also for leadership, directors and managers, you know, across the board as they prepare to be able to address this and make sure that new nurses that are coming in really know what they're doing when they get into the operating room. So maybe you could just talk about your role at the Trudy Busch Valentine School of Nursing and really how you came upon this role and why you're so passionate about it.
Sure. So I started grad school at St. Louis University in 2013. I wanted to advance myself, but I wasn't necessarily interested in going down the nurse practitioner route. So our school is very fortunate that we have a non-nurse practitioner route that it allows you to end up with a master's in clinical nurse leadership, which kind of focuses on quality improvement, but nursing education as well, which I kind of have more of a passion for, and which is why I'm taking on new grads in the OR, teaching students. And during my program, I was doing in the nursing education route, we had to come up with like our own class, like an elective or something that suited your need. And I thought, a perioperative nursing elective, this would be really fun. So I came up with the course. I kind of had this in my mind, how I thought it would look. And as many grad programs too, you have a mentor that you sit down and talk to. So I sat down one day with my mentor and was presenting this to her. And she said, this seriously could be a really good elective for our students. We're looking to expand our elective programs here at the university. So when I graduated, she kind of took me under her wing. We presented it to the core faculty at the university, and they were extremely supportive and jumped right on board. And we kind of had to take my class and kind of finagle it to how the university would set things up with policies and that kind of stuff. But they really enjoyed the bulk of it. So in spring of 2020, we actually launched the perioperative nursing course at the university. We started with 15 students. Of course, with COVID, kind of messed up the first year doing this, but this past semester was able to do a full semester. It's kind of a hybrid course. It is online lecture for the first 6 weeks. Students learn the history of nursing. They learn about the pre-op nursing, PACU nursing roles. They learn inter-op nursing. They learn the scrub role, the circulator role. We talk about different types of safety equipment, safety of patients in the OR, how that nursing is different from floor nursing that they're extremely used to. And then we do 3 weeks where we discuss all the different types of surgeries. We just kind of go head in the different specialties.
So, Lindsey, what's interesting is, this is meeting a huge need. And when I got into nursing, we didn't really have anything but maybe a shadow one day for, I'm not even sure it was a full 8 hours. It might have been 6 hours, maybe 1 or 2 cases, smaller cases, definitely not something, long like an orthopedic procedure or anything like that. And I don't even know that anybody really coming out in my graduating class anyway, it really had an idea of what was going on. And I think sometimes new nurses are intimidated by that surgical environment because of that lack of exposure. So, just take us back to your own personal experience. How did you receive your training for the operating room?
Sure. So I was like you had that 1 4-hour observation day during nursing school. Surgical nursing and education's come a long ways from like the 70s and 80s where they could have anywhere from 4 to 6 weeks of strict surgical nursing within the curriculum. So I did an observation day and I just knew it was for me. And I was very fortunate to be one of several in my class that got to actually choose a specialty for their preceptorship our last semester of nursing school. And I did actually get to go to the operating room. I did 6 weeks of one-on-one with a preceptor. And that actually led to a job as a new grad in the operating room where I was working at the time. So I was one of the few new grads that they actually took straight to the OR in this program. A lot of times it had been mostly people that had transferred from the floor with Med-Surg background.
So that's really interesting too, because you had a unique opportunity, kind of unprecedented, and then you got hired right in as a result of that experience. How long did it take you to really feel competent as an operating room nurse?
Oh my gosh. So it was a 9-month program where we kind of learned the basics of how the OR works and what a circulator scrub does, and then going through the different specialties. But I would say it was at least 2 years before I felt like a competent operating room nurse. And that's still, as 2 years, that's still a baby nurse. But I was very fortunate to have some very good mentors at the time who kind of took me under their wings. They could tell I wanted to learn. I wanted to learn more. And actually then as a new nurse, I went to weekend options. I was working at a level 1 trauma center at the time, running a 24/7 operating room. So I actually went to weekend options because I just wanted to learn more. That's where I really learned the bulk of operating room nursing, because it was, you did anything that was thrown at you at any time of day. And I tell the new grads and new nurses, even who transfer from the floor that come down with me, that, look, it's going to take you at least a good year or two before you feel like you're a competent operating nurse. If you don't feel that way after your 6 months of training or however long, it's okay.
Well, I definitely would agree with you there. You know, you talked about having that elective program to take OR nursing while you were still in school. I did train in the 70s, and we had one day in the OR as well back then. I think you were very lucky to have a program like that at your school where you could choose an elective and go in the operating room. I think the boards of nursing at different states impact the criteria for graduating, but it's also, I think, the NLN that has some say in that as well. And I thought they were the ones who had taken OR out of the nursing programs, but maybe now they're bringing it back in. That would be wonderful if they are. I hope that's the case. So let me ask you about taking call, because I know when I finished my training, the first night I was on call, of course, I didn't sleep all night. I was scared to death that I was going to get called in and not know what I was doing. So at what point do your students start to take call in the operating room?
Well, Paul, 13 years later, I still don't sleep well on call at night because I'm really afraid I'm going to miss that phone call. So at a lot of facilities, the training program for a new transfer is at least 6 months. The kind of standard training program now is AORN's Periop 101. And that's a minimum of a 6-month orientation. So at a lot of facilities, once students make it through that program, it's deemed competent that they can be an operating room nurse on their own. That's typically when they'll start taking call. They're usually not going to take call immediately on their own. A lot of places kind of have a buddy call system set up where the new person is with an experienced nurse who's on call. And at least at my facility, and I know other facilities as well, they'll try to buddy that person up with someone where the opportunity for them to get called in is going to be high. I know a lot of hospitals do call in different ways, but they try to put them at least on, if there's a case, they're that first person and they're going to get called. That way they get that experience of kind of coming in and not knowing, you know, am I going to do orthopedics? Am I going to do general? Am I going to do neuro? How do I clock in to make sure that I'm getting paid correctly? And then I think it's a good way to see their critical thinking in action. So like, you know, maybe their last 2 weeks of orientation, you know, if they were doing, I don't know, say vascular, for example, and then they get called in and they have to do an emergency ortho case and they haven't done ortho in 3 or 4 months, it kind of takes them back to, well, remember your orthopedics, what do you need? And kind of gets that train going that, you know, you have to be on top of everything at any given moment because you could be tossed into any situation.
What is your recommendation in terms of how to rotate people through the various specialties, and how long should they have a focus in a particular area as they're going through their training? Is there a sequence that you prefer them to go in as they're going through those rotations?
Sure. I think the sequence for sure. I think a new grad needs to start out in like general surgery. So, you know, your laparoscopic cases, your hernias, your exploratory laparotomies. Majority of time, that's typically what they're going to get called in to do. But I think it also provides a very good basic foundation for how to be at least a circulating nurse and, you know, basic scrub as well. Usually I'd say maybe 2 to 3 weeks per specialty, kind of depending. I know a lot of specialties kind of have their own call team. So a lot of orientations are more focused on the circulating aspect. And then maybe towards the end of a orientation, if they decided, oh, you know, there's an opening on the ortho team, I'm going to go to ortho, they can kind of do their own specialty orientation to come to scrubbing in that aspect. I think you should hold off on your more critical specialties, vascular, cardiovascular, hearts, towards the end of the specialty, once that orientee kind of has a better grasp of how to be a circulator and kind of gets that critical thinking in the OR a little more at hand, because it's very on your toes. You got to make a split-second decision in some of those areas. Whereas in general surgery, orthopedics, maybe you have some time to think like, okay, where do I need to go next?
So at the very beginning, you were telling us about the program that you designed, and you're saying a critical part of that was that everybody would begin, to learn all the different procedures. Is that part of them spending time in each specialty, or is that almost like a precursor part of the program where they get that exposure and then they go get hands-on? How does that layer on top?
So in our course, we spend 3 weeks discussing the different specialties and going over, I kind of highlight the main surgeries that they might see. Obviously, there could be some surgeries that I don't go over that they might see, but it kind of really gives them insight as to how a surgery is performed. And I think it kind of adds on, they learn about the pathophysiology of somebody having, for example, say gallstones, and they've tried to change their diet and they've tried to lose weight, but then those things don't work. So then they see that surgery is the next option. And then they kind of go in and see how that surgery operates, what's exactly done. And then that kind of gives them a better idea that, if they don't want to work in the OR, they have a better idea of how to take care of this patient post-operatively. I've had several students go to operating rooms across the country as new grads, and just having that knowledge of different surgeries and how they already are conducted kind of gives them a little advantage in their orientation program versus others. We've also had new nurses on the floor, say orthopedics, who will come down and observe surgeries for the day. And it just really gives them a better insight as to why their patients, say, are in so much pain post-operatively. I had one nurse one day watch a whole day of total hips, and she's like, I see why these patients hurt so much after surgery once they see what we're doing and how we manipulate them. And then she said it just was going to give her a better idea of how to take care of their pain post-operatively.
Oh yeah, you don't want to hold up their pain medication, that's for sure. I want to ask you a little bit more about your program as well. And you start off with the 6 weeks or so of didactic training. After that, now, are all the nurses from the same facility? Do you have nurses from multiple facilities? And are they already hired in the OR so that when they finish your program, they go directly into their clinical rotations?
So we use two different facilities here in the St. Louis area just because the past 2 semesters we've had 12 students in each class, and that's a lot to ask for one operating room to take on, especially when they have other guests coming in, other students, other observers. So we have 2 clinical facilities actually here that take them on. They split them up 6 and 6. They do 3 full clinical days, 8-hour days. One day they do a pre-op PACU day. They spend 4 hours in the pre-op area in the morning, helping to get patients prepared for surgery. They spend the afternoon in the recovery room seeing what the recovery room nurses do. They get exposures a lot of times to, drains, tubes that they might not get to see on the floor, cardiac events sometimes that occur. They get to pain medicines. And then they spend 2 full days in the operating room with the circulator. Just due to policies at the facilities, the students are not allowed to scrub. It's hands-on, patient-centered care as a circulating nurse. I intentionally don't have the students charting. You can learn to chart anytime, I think. But they're hands-on with their circulator at the OR table with them. So they're helping anesthesia with induction and extubation. They're helping position, and they're prepping. They're with the nurse. They're learning how to count. Basically all the roles of the circulator. I like to say, put them to work. If your nurse is turning over and mopping the room, nothing is beneath you. You're going to do this as well. Our university has a lot of out-of-town students, but we do have some students locally that have done the course, and educators have said, we're willing to take on a new grad. So as long as they've taken your course, we'd be willing to find a job. So I've had 3 or 4 students at least who have stayed in the St. Louis area and have gotten jobs as new grads. I had one student get a new grad job in Chicago and one in Atlanta as well.
That's going to be so critical to dealing with this staffing issue. Is we can't wait for the nurses to go out into the field and work a few years and then find their way to the operating room. This is totally the way to design it. And I can see where it's such an advantage. And you were just talking about their time, literally working in the job side by side. But what do you think about 1-to-1 on the job training? And is that actually what you're providing? Is that a 1-to-1 relationship when they're getting their hands on?
Yeah, so it is a one-on-one. They're with that nurse at least for that day. They might be with a different nurse when they go a different way. It just kind of depends, but they're with that nurse one-on-one all day. I think as a new grad in the OR in an actual program where they're hired in as a nurse in the operating room, I think there is some pros to one-on-one. As you said, it can be very stressful, high demanding, intimidating environment. So I think if you have that one-on-one training, with a preceptor for a while, you at least can kind of cut that vulnerability down. You can have those one-on-one conversations. Like hopefully the orientee would feel comfortable with their preceptor that, hey, this scares me. I don't know about this. How do you handle this situation? Whereas if they're jumping around from multiple preceptors, they might not feel as comfortable saying they're scared or whatever.
Lindsey, I've got a couple of questions for you about this. The first one being, do you give guidelines to the preceptors in terms of what the goals of the day are or what areas you want the student to focus on when they're there? And number 2, going back to what you just said about having multiple different preceptors, one of the things I've found over the years is that when multiple preceptors are involved with one student, they may have different ways of doing a particular task, and then the student can get confused about what's the proper way to do it. So how do you set them straight when that occurs?
So yes, we do have guidelines for them. There are certain things university-wise nursing students just aren't not allowed to do. For example, they can't check blood products. They can't hang blood products. So that has to be done by a nurse, but stand by your nurse and watch them check the products. Basically, whatever hands-on that the preceptor feels comfortable with the student doing, let them do. So, if the case requires the patient to have a Foley catheter, these students who are in this program are seniors getting ready to graduate. They've done that skill. Let them stand there and do it. At the same time, I tell my students, if your circulator senses that it's not within the best interest, they kind of can read the environment a little bit better. Don't be offended if they say, hey, let me do this, because it's just going to kind of make the day a little bit better. As for the multiple preceptors, I think there's a pro and con to it. The pro being, like you said, they could see different nurses doing different things. And while they might be doing them differently within the guidelines, it kind of can help them see different ways to do different tasks, and that helps them design their own nursing practice. When I was a new nurse, I was with a preceptor one day, and she sent off a frozen section for a specimen, and she came back and she wrote the time on the board. And she said, I always write the time, so I know, they should be calling me in 15, 20 minutes. And if I get distracted, I can turn around and say, hey, I sent this off at this time. 13 years later, I still do that in my practice because I thought that was such a great thing. At the same time, you would hopefully have that educator or leadership in your department that's going to sit down with the new nurse and say, show them the policies that, hey, this is how things are done. This is what we have to go by. Again, it's about that trust to be open and vulnerable. What are you seeing and how can, because maybe that preceptor has learned something differently or doesn't know the policy and needs to be educated themselves.
So this is a great program for senior students. And what I can see is that there might be an opportunity to open this up to nurses that are already practicing and drawing in nurses from other local hospitals. One of the things that through the years that has always been an issue for me is that frequently a hospital will hire a full-time educator and only train 2 or 3 nurses at one time. And they're spending that 6 months with those 2 or 3 nurses. That's very expensive, not only for the nurse's salary, but for the educator's salary. So by pooling the resources and having 2 or 3 nurses from multiple hospitals going through your class at the same time, and then just having the educator help with the preceptoring or the clinical portion of the class, the hospitals would get a lot more bang for the buck, wouldn't you think? Is that something feasible that you'd be able to do in your program?
I think orientation-wise it would be, because usually a lot of orientation programs, that first 6 weeks, it's basic, Periop 101, how to be a circulator, how to scrubs, your sterile technique, prepping, draping. You could definitely pool your resources together and train multiple nurses at once in that vicinity. Every hospital, even within the same system, is going to operate differently. So one system could have a level 1 and a level 3 hospital, for example, and those 2 operating rooms are going to work differently. And then it's all about surgeon-specific preferences as well. So I think if you could pool them all together for sure for those first 6 weeks. We actually have a local system in St. Louis that does do that. They pool, 4 or 5 new OR nurses from the different hospitals. They meet together with the different OR educators for 6 weeks. Then they go back to their facilities and learn their facility-specific policies and operations.
This is really the business of healthcare component, where you're trying to balance the costs, and really, especially for surgery, the costs have never been tighter, and there's never been so much scrutiny. It used to just kind of be do whatever you need to do back in the 80s and 90s, and things really began to change, especially with accountable care. And so staying on that cost piece, so let's say when you're training somebody for the operating room, should they be responsible for that cost? And especially if they end up leaving prematurely. And there may not be a clear answer on this, but maybe what are the considerations around that we should all be thinking about? Because that's really going to be a big concern for a hospital with new grads, right? Is we have somebody that we don't know if they're going to like this or not, or if they can do it. So if we start paying for that and we're only getting 20% of those graduates to actually come and work for the hospital, now we're kind of, we're taking a big financial load on.
So the average cost to train an OR nurse, whether it's a new grad or transfer, is approximately $15,000. And that's just the education portion. We're not even talking about salary for the nurse or their preceptors. Like you said, it's not clear cut. Should some people pay back? Yes, it does depend, but it's going to depend on their circumstances. If they had a family issue, or say their spouse gets transferred to out of town where they have to up and leave. Some circumstances are just out of their control. Maybe they wanted to stay. Maybe these nurses who transfer to the floor, these new grads, think this is exactly what they want to do, and then they get there and it's not what they thought at all, which is why I always recommend to, whether it's a new grad or even if somebody who wants to transfer from the floor, that, hey, ask your facility if you can come shadow for the day. Most ORs are happy to have people come down and see if this is what they want, because management and educators know that this isn't for everyone, and it's not what, I think floor nurses have an idea of what OR nurses do, and it could be a big surprise to them. So have them, let them come down and see if this is really what they want to do, and if they want to invest in their time and effort as well to learn a whole new specialty of nursing.
Yeah, I love the shadowing piece. And the truth is, you just described it. If it takes $15,000, regardless of whether or not they're a new grad and the shortage is coming, I think what you're really telling me is the burden of this cost is there regardless. So why not have a formalized program, in a partnership with the university to help maybe set that shadowing up, make sure that that's something that they want to do, and help ensure that if the hospital is going to bring them on board, that they are more pre-qualified than maybe other candidates who don't have operating room experience previously.
And I think they're starting to understand that nursing schools are taught to teach to students to pass the NCLEX. And NCLEX is very Med-Surg heavy. So that's where they're going to teach them. They're not going to teach them critical care or emergency room or operating room. So these students think that they have to go work in Med-Surg for 2 years before they could go do something else that maybe they really feel called to go work in the operating room. So I think they're starting to understand that there's a nursing shortage regardless. I don't have to tell you guys that. AORN predicted in 2019 that by 2022, there was going to be at least a 60% shortage of nurses in the operating room. Now, I'm sure COVID has changed those numbers, obviously, but regardless, the boomers are retiring. And, you know, if it takes 6 months to a year to train an OR nurse before they feel competent, we got to start that now. So if you can get these students in for a full day or a semester to see if this is really what they want to do, start it now so we can start formulating it.
Lindsey, I have one last question for you, and that has to do with the selection process. In my experience, it seems that OR nurses are nurses that like to have instant gratification. They want to go in, take care of a patient, do the case, and feel gratified at the end that they did a good job. How do you interview for that? How do you ensure that the candidate that you're selecting is the right one, that they're going to be able to make it, so that we ensure that we aren't wasting a lot of money trying to train people that really aren't the right ones for it?
Excellent question. You almost just need a different type of nurse. Like I've always felt like you either work in the OR or you don't work in the OR. You know, like you said, somebody who just has that passion for patient care, patient focus, family focus, you know, they get that one-on-one patient interaction. I don't have to worry about anything else except that one person in the room, whether it's 8 minutes or 8 hours.
I would think that there's a lot of that personality type that fits well in the emergency room that would also fit well in the operating room, because it's that cool under pressure, you know, type of person that I think fits in really well.
It's a lot of type A's working together. You know, we're perfectionists. Like you said, we kind of want that instant gratification and well organized and a desire to learn. I mean, you know, I can do 8 hours of lap choles. I'm going to have to formulate my nursing plan a little bit different for every single patient. It's not the same treatment plan day in and day out.
Okay, Lindsey, one last question here. And I think it really has to do with the fact that obviously it takes a different kind of person to work in the operating room. So, you know, whether they're a new grad and you're trying to figure out if this is a good program for them, or it's a hospital who's looking to have somebody, even if they're doing it on their own, but there's got to be certain soft skills or personality traits that everybody should have, or at least are in common to be successful in the operating room. What would you say to that?
I think one big characteristic is you have to have somebody who's flexible. Not that you don't have to be flexible to work on the floor. I'm not saying that, but flexibility is huge in the operating room. You know, you could spend 20 minutes getting set up for a case, turn around, it's canceled. You could just walk back in from lunch and they say, hey, you got to go do this emergency right now. So really quick thinking on your feet in the spur of the moment, which also comes with time and experience as well.
Lindsey, really great job in this interview, but I'm going to say even a better job putting this program together, identifying a need. And I really love how you came about it. You didn't even realize that the reason you were doing it was going to actually lead to its fruition. And I just think that that's an awesome story. Before we wrap up, is there anything else that you'd like to add? Because this is clearly a labor of love. And whether you know it or not, you have an entrepreneurial spirit for getting this off the ground.
Yes. In 2014, when I presented this at one of my class presentations, I didn't think that in 2021 I would actually be implementing it. So I think we need to take new grads under our wings in the OR. You know, we need that next generation of OR nurses, and we got to start training them now. The OR nursing field is kind of a very exclusive group that they don't want to bring anyone else into their little field, but we need the next generation of nurses to take care of our surgical patients, and we need to start that now.
Yeah, truer words could not have been spoken, and really time is of the essence. Nice job today. Thanks for coming on.
Thank you.
That was Lindsey Joyce, RN, MSN, CNL, and CNOR, a cardiovascular operating room nurse at St. Luke's Hospital in Chesterfield, Missouri, and for the topic of this interview, the coordinator for the Perioperative Nursing Elective at the Trudy, Busch, Valentine School of Nursing at St. Louis University. And Paul, I just remember I really, as I mentioned during the interview, only had maybe 4 to 6 hours. It was a one-day rotation in the operating room. And I remember everybody saying, oh, I'm not going to go do that. That's very intimidating. And a lot of times things are intimidating because you don't really get true exposure, to the environment in that role. And I also remember that many of my instructors in nursing school, and I'm going back to the 90s now, but they were talking about how when they came in, they really had more hospital-based programs for training because there was a shortage, and a lot of them came into nursing in the 70s. It just makes so much sense to me, especially as it relates to surgical services and working in the operating room. But not only that, she talked about pre-op and post-op and the PACU. I think just getting more and more exposure to that area is going to help. There's a general nursing shortage, but if you already have some nursing students and new grads that are reluctant to go into surgery, it's only going to hit this environment that much harder. And so I think having programs to increase exposure, increase confidence, help validate competency coming out of nursing school and into the workforce, it has to be good for the industry.
Oh, and it's so needed. It's so needed. I remember when I was in training in the late 70s that I had a half day in the operating room, and that was it. Luckily, I was working as a nurse's aide in the operating room when I was going to school, so I had that exposure. So I wasn't afraid of it. I think if I had gone into the operating room after I graduated from nursing school and gone in there for the first time, I would have been intimidated and never would have made it. It was really important. And I think another thing that we need to touch on is the fact that these programs, even the ones today, really don't teach very much in the area of scrubbing. That generally comes much later on after a nurse has been circulating for a while. I was in an on-the-job training program in the 70s, and we actually learned to scrub first. I found that to be very beneficial because by learning all the instruments and learning all the steps in the procedures, I felt a lot more confident when I did start to circulate. And it was much easier to know what was going on in the field with that knowledge of the steps in the case. And you get some of that when you're going through your program, but it's not like actually doing the cases. So I think Lindsey is providing a great service to the community in St. Louis, and there needs to be a lot more of these programs.
Yeah, I would love to see more of them popping up. And, you talked about the scrubbing. It just reminds me of our discussion with Megan Mullinax. And, even as you talk about your career, Paul, having been able to work from at every level all the way up to CNO, and how much credibility that gives you and how much confidence you had, as you were just saying, having scrubbed before circulating, to that you really understood the nuances. So when you're talking to that audience, or you're trying to collaborate or partner or get the job done and pull together as a team, it just, I think, really helps everybody be in sync. And so that's another key component. I really like that you brought up the scrubbing piece today before we wrap. But that's going to do it for this week's show. As a reminder, you can help support First Case by subscribing on Apple, Amazon, or Google Podcasts, Stitcher, iHeartRadio, Spotify, or on your favorite podcast application. You can also access bonus content for certain episodes by downloading our smartphone application for iPhone and Android. We'd certainly appreciate a rating and a review because your feedback is important to the show. And on behalf of Paul and myself, thank you for listening to this week's episode of First Case.